I'm Ola Landgren. I'm professor of medicine. I lead the myeloma program at the University of Miami. Today, I will talk to you about the ADVANCE clinical trial, which is a multi-center study for newly diagnosed patients with multiple myeloma. And this was done here in the United States. I presented this at ASCO 2025, and this was also presented at EHA of 2025. The key takeaways from the study are that the primary endpoint of MRD negativity 10⁻⁵ by next-generation sequencing in the intention to treat population was higher in the dara-KRd arm compared to the control arm, KRd, 59 versus 33%, an odds ratio of 2.9, highly significant. The second takeaway is that at 31.2 months, median follow-up, 92 versus 83% of patients are progression-free on the dara-KRd versus the KRd arm. And there's a trend for significance. There are no new safety concerns with the four-drug combination. And lastly, we conclude that the dara-KRd should be a new standard of care for newly diagnosed patients with multiple myeloma receiving the initial KRd backbone therapy. The background for this study is that the use of modern combination therapy in newly diagnosed patients has led to more and more deep responses, i.e. MRD negativity. And we have seen this independent of transplant eligibility. With the development of MRD negativity as an early endpoint for accelerated drug approval, which we pioneered and presented at ODAC last year with the FDA, together with the I2 team, there's an opportunity to design clinical trials for newly diagnosed patients independent of transplant eligibility. This is exactly the basis for the ADVANCE study. This was designed to offer newly diagnosed patients with multiple myeloma access to modern and effective combination therapies independent of transplant eligibility. So this study is open for both transplant eligible, transplant ineligible, and transplant deferred patients. A total of 306 patients were randomly assigned one-to-one to receive 8 cycles of either dara-KRd or KRd. Carfilzomib was given weekly, 56 milligrams per meter square. We used optimized fluid, meaning IV 250 milliliter saline just before the first cycle of carfilzomib. So cycle 1, day 1, cycle 1, day 8, and cycle 1, day 15. Thereafter, no IV fluid, very important. We also used oral factor Xa inhibition to prevent coagulation. So we don't use aspirin. So if you do that, you don't run into DVTs or PEs when you give these effective therapies. Stem cell collection was encouraged after 4 cycles for eligible patients. After completion of 8 cycles, patients were evaluated for MRD. And transplant was recommended for patients that were MRD positive after cycle 8. But for patients that were MRD negative after cycle 8, the transplant was deferred. The primary endpoint, as I mentioned, was MRD negativity, 10⁻⁵, using next-gen sequencing. And we used the only FDA-cleared assay here in the US, the clonoSEQ assay, to determine that. And again, that was after 8 cycles of combination therapy. So here you have a graphical overview of what I just went over with you. 4 cycles, collection of stem cells for eligible patients, another 4 cycles, and then determine MRD status. And for MRD negative patients, they went to maintenance. And for MRD positive patients, if they had collected stem cells and are eligible, transplant was recommended. Here we have the beginning of the results. The baseline demographics, as you can see, indicate that the average age was around 60 years. There were slightly more males than females. The majority of patients had a performance status of 0 and 1, similar to most other studies in this indication. Also, the ISS 1 and 2, the majority of patients, similar to most other studies in this indication. Around a third of the patients were high-risk disease. And you can also see that there were slightly more high-risk patients on the dara-KRd arm. Here we have the primary endpoint, MRD negativity 10⁻⁵ by next-generation sequencing after 8 cycles in the intention to treat population. And it's significantly higher in the dara-KRd compared to the KRd arm, 59 versus 33%, odds ratio of 2.9, highly significant. The secondary endpoints included stratifications of the MRD results. And here you have the first secondary endpoint, MRD negativity by age. And as you can see, patients below or above the midpoint, around 60, they perform equally well. The 4-drug combination is superior for both these groups of patients. We also stratified by high risk and standard risk. And here you can see the delta, the improvement of MRD negativity by adding daratumumab was around 20% in the high risk group and around 30% in the standard risk group. You also see that the p-value is not fully significant for the high risk. There's a trend. This is because the numbers are smaller. There are fewer patients. So with a larger study, you presumably would be significant. But you see that there are clearly improvements for both groups. Our take here is that patients with high-risk disease, they clearly need a better therapy, but the better therapy will always work the best in standard risk patients. So the basis for thinking about risk-adapted treatment, we think, is flawed. Instead, give every patient the best therapy in every line. That's the way we practice. The secondary endpoints also include progression-free survival. At 3 years of follow-up, about 92% of the patients on the 4-drug combination are free from progressive disease. This is a very strong result. And as you can see, there is a trend for significance. And given what we worked on with ODAC last year at the FDA, we anticipate with a little bit longer follow-up that the very strong correlation between MRD negativity and progression-free survival is going to take us into significant progression-free survival here with longer follow-up. We will obviously have to wait till the data is mature. We also looked at event-free survival as part of the secondary endpoints. And here, events capture progression, death, or change of therapy. And we know, in particular in the United States, that a lot of physicians are changing therapy because they feel that would be the right thing to do. What happened on the trial was that there were patients that were transplanted, although they were MRD negative, or that could be an addition of some other drug on the maintenance arm, for example. And that's here captured as an event. Yet the dara-KRd is superior to the KRd. When it comes to safety, importantly, the safety data is consistent with the established safety profiles for each of the individual drugs. And overall, the 2 study arms had comparable rates of treatment-associated adverse events. That's also true for the serious adverse events. The safety data is consistent with the established safety profiles for each of the individual drugs. There were 2 deaths on the dara-KRd arm. They were both due to sepsis, and there was 1 death on the KRd arm, which was due to progressive disease. Overall, the 2 study arms had comparable rates of treatment-associated serious adverse events. A very important result of this study is this is an investigator-initiated study done in the United States, enrolling as many as 306 patients. This was done at only 7 independent academic institutions. I think this is a great accomplishment that so few sites can enroll so many patients here in the US. Many of the cooperative group studies have hundreds of sites, and many of the company-sponsored studies have that as well. This is really a strong result, and we're very proud to be part of this team with 7 institutions. Again, the key takeaways are that the primary endpoint of MRD negativity, 10 to -5, by next-gen sequencing in the intention-to-treat population is higher in the dara-KRd arm, highly significant. At almost 3 years of follow-up, 92% of the patients on the dara-KRd arm are free from progressive disease. There are no new safety concerns with the therapy. We conclude again that dara-KRd should be a new standard for newly diagnosed patients with multiple myeloma that receive initial KRd backbone therapy, independent of transplant eligibility. Looking forward, this is an investigator-initiated study, randomized, multi-center, newly diagnosed patients. There's very strong focus on translational research. We have a whole list of multi-omic assays that we're going to pursue to try to understand better what are the mechanisms of sustaining MRD negativity or patients that unfortunately don't reach or lose their MRD negativity. What's the basis for this? And to predict clinical outcome in relation to MRD and therapy with or without transplant. And we really would like to collaborate with other groups, and we invite other groups to reach out to us so we can share data with each other and help and advance the field. Also, we have already developed and just launched the Advance 2.0 clinical trial that uses a bispecific BCMA CD3 targeted monoclonal antibody, elranatamab, in combination with DKRd. And this is just opening for enrollment for newly diagnosed patients. We would like to thank all the participating patients and families. And also, we would like to thank everyone on the entire team across all the different institutions, this 7-institution collaboration. And I would like to thank our funding support from NIH, Tau Foundation, Riney Foundation, and Myeloma Solutions Fund. And this study, as I mentioned, is an investigator-initiated clinical trial, and it's been supported by Amgen and J&J. Thank you very much for your attention. Thank you.